Hello, I'm Jenna from the Changing Futures Community Engagement Service. As March is Brain Injury Awareness Month, and as traumatic brain injury is often linked to the areas of SMD, it's important for us to understand the causes and impact that traumatic brain injury has on different people. We will briefly be discussing topics that you may feel uncomfortable with, such as domestic violence and trauma. Please close the video and take a moment if you need it. First, why does recognizing brain injury matter? Overall, traumatic brain injury, or TBI, is common but under-recognized and often hidden. This means that many people have experienced traumatic brain injury but either don't know it or other people haven't noticed the symptoms. In the severe and multiple disadvantage, or SMD population, traumatic brain injury is overrepresented. In a group of people facing SMD, there'll be a higher chance of someone having a traumatic brain injury than in the general population. This is because there is a high link between traumatic brain injury and substance use, criminal offending, homelessness, and domestic abuse. Coming from intersectional identities can also increase someone's risk of experiencing a traumatic brain injury, reduce access to proper care and rehabilitation, and can even worsen outcomes compared to other identity groups. We'll be exploring why this is the case throughout this video. What is brain injury? It is any injury to the brain caused by external force or a period of unconsciousness. It can also range from mild injury to severe. Effects of a brain injury can include memory and attention difficulties, such as recalling past events or concentrating on a task, impulse control problems that may lead to saying or doing something that those without brain injury can stop, emotional regulation issues, fatigue and sleep problems, and executive dysfunction, in which the brain can't control thoughts, emotions, and/or behaviour. There can be many causes of a traumatic brain injury that include a hit to the head, either through falls, a vehicle accident, or a sport injury, or through physical violence like a fight or being a survivor of domestic violence, or from non-fatal strangulation, or through internal damage such as infection, a tumour, a stroke, or toxicity and poisoning through things like carbon monoxide poisoning or alcohol and substance use. I spoke a lot about severe and multiple disadvantage, or SMD, but what is it? Someone facing SMD will be dealing with 3 or more of the following disadvantages at the same time: alcohol or substance use, poor mental health, homelessness or being vulnerably housed including sofa surfing, criminal offending or as a victim of crime, or being a survivor of domestic or sexual violence and assault. Traumatic brain injury numbers are generally higher in SMD populations due to the increased risk factors of development and symptoms after injury. This means the causes of a traumatic brain injury is heavily linked to the disadvantages of SMD and the symptoms that come after the injury. For example, a brain injury can increase the risk of homelessness, increase risk of exploitation, affect engagement with services, potentially having the person refuse any support, and can increase the risk of reoffending. Let's look at this more visually. There are the experiences that can lead to a brain injury and the experiences as a result of the injury. These can both exacerbate each other, leading to a vicious cycle for that person. We know that alcohol and substance use can lead to a brain injury, and we know that being a victim or survivor of violence can too, particularly through domestic violence or being a victim of a violent crime. Then, once the person has a brain injury, they can experience thinking and memory problems, physical changes such as how they interpret the world through senses and their body function. There may be behaviour changes, particularly around concentration, motivation, or emotional and impulse control, and there may also be a personality or mood change. Brain injury can also lead to poorer mental health and increased risk of homelessness, and all these things can make each other worse. For example, someone experiences a traumatic brain injury from heavy substance use and a violent fight. This can lead to a lack of emotional and impulse control. That person is then at a higher risk of taking substances again due to an inability to control their impulses, and they may get angrier easier too due to personality or mood change. This can lead to more fights, more violence, and further injury. On top of that, there is an intersectional overlap with risks and outcomes of a traumatic brain injury. Intersectionality refers to our identity and how it is made up of the different groups we belong to. The combination of our identity and lifestyles can affect our chances of acquiring a brain injury, but also impact access to appropriate treatment. In this video, we'll be exploring the relationships between these intersectional groups and brain injury. Let's go. Our first group are refugees and migrants. This group comes with an increased chance of acquiring a brain injury. These are risk factors. Someone from this group may have suffered injury from conflict in their home country. Being a survivor of torture or assault in their journey or home country, being a victim of trafficking can put them at risk of violence or trauma, and they may have undergone a dangerous journey that could involve head injury or passing out from exhaustion, dehydration, or starvation. There's also barriers to receiving proper support, such as language barriers, maybe explaining what has happened or how their feeling is difficult, cultural stigma, sometimes physical or mental illnesses are kept hidden as they aren't recognised or spoken about. There may also be limited access to or knowledge of our healthcare systems. Perhaps they can't access anything, or it's expensive for them, or they're just not sure what they're entitled to. Symptoms may also be missed by healthcare workers, or may be seen as a result of another trauma, not brain injury. For ethnic minority groups, they are underrepresented in traumatic brain injury research. This means that the differences in experiences between ethnicity groups can't be used to help change systems. However, there are some things that we know. Some cultural perceptions can change or limit the way people talk about or treat a brain injury. For example, a traumatic brain injury may not be seen as a result of external force, but may be seen as a spiritual event, a curse on that individual, a defect, or a consequence of fate. Similarly, people may choose other medical practices to treat the brain injury outside of UK medical guidelines, or may receive care from the family only. There are also some extra things to consider, like structural racism affecting access to care, whether it be from the system itself or fear of discrimination. Adverse experiences in rehabilitation referral and outcomes. There's evidence to suggest that people from ethnic minority groups are either not referred to appropriate aftercare or not even referred at all. There may be a lack of knowledge of traumatic brain injury, or they may not accept it once they've been diagnosed. Not every country has the same medical terminology or diagnoses, so it's important to talk about it in a culturally competent way. And there's often high levels of stigma or shame around both the causes of a traumatic brain injury and the different changes that come afterwards. This can affect the person's ability to talk about their symptoms, accept their injury, and recover. Next, we'll look at the LGBTQ+ community. There are some differences between the sexual identities and gender identities, but overall there are higher rates of interpersonal violence that could lead to a head injury, higher rates of homelessness that we know can increase chances of acquiring an injury. There is increased exposure to hate crime, more so if they are transgender or non-binary, and there is a higher chance that they may use alcohol or substances, which we know can lead to an internal cause of traumatic brain injury. The community may often avoid getting support out of fear of discrimination in services. There is also a lack of LGBTQ+ competent support. There's a looming fear of not being taken seriously as a member of the community, and it can also come with high stigma or shame. These can all come from accessing care for a traumatic brain injury or for getting help with risk factors for an injury like substance use or domestic violence. There are also major gender differences in brain injury too. In women, a traumatic brain injury is more likely to be the result of domestic abuse. They are also more likely to be underdiagnosed, and while they're less likely to experience a traumatic brain injury, they'll have worse outcomes if they do. Whereas men are around 40% more likely to suffer from a traumatic brain injury than women. It's also been found that within the criminal justice system, 68% of men and 50% of women reported having a traumatic brain injury. That's almost 7 in 10 men and 1 in 2 women. The mortality rate of brain injury is also different. In women, it's higher between the ages of 15 and 50 years old, but for men, it's much higher after 50 years of age. And for transgender and non-binary people, there is increased violence exposure that could lead to a traumatic brain injury, but limited research and support to understand the differences. Traumatic brain injury is also heavily linked with neurodivergence. This is a term used to describe the different ways people perceive and navigate the world around them. It includes autism, ADHD, OCD, dyslexia, and traumatic brain injury. Symptoms of a brain injury can overlap with these other neurodivergent conditions, such as high impulsivity, executive dysfunction, and emotional dysregulation. Traumatic brain injury may worsen symptoms of a pre-existing neurodivergent condition. It may be misdiagnosed as intentional misbehavior, or it may go unnoticed if support needs already existed before the injury. So what to do with all this information? We've learnt how risks and implications of a traumatic brain injury can be different in each group, but what can you do? You can screen for head injury early. This can allow for the right conversations at the start and create better informed support plans. You can consider cumulative injuries, such as in domestic abuse survivors. Perhaps there's been multiple injuries over a long period of time. You should use accessible communication and intervention structures to ensure that the person can meaningfully take part. This could include shorter sessions, repetition of information, or written instructions for the person to keep. You should ensure that you're up to date in improving cultural competency and that you be inclusive and intentional when designing intersectional services. Always consider the different ways that people live, think, and react. And remember that cognitive difficulty or traumatic brain injury symptoms are not always non-engagement, so shouldn't be treated as such. Thank you so much for listening and learning with me. For more information or tools on brain injury and SMD, please pause the video and use these links. Or head over to these places to learn even more about the brain and how brain injury can impact people's lives.